I'll ask Dr. Viveka Kumar, what's your opinion, sir? So you're running a program on a heart attack. What is your recommendation? You got the services. What kind of network we should create in Delhi so that we can approach to government and we can approach to non-government organizations like they are doing in South. They are very active in South and they have a very nice network and very good care. They provide to all the patients. Most of them receive thrombolytic agents before they reach the hospital. I'd like to have your clear message as Vinod has given, pre-hospital clot lysis followed by angioplasty. What do you say, Viveka sir?
Yeah, so I think as we know that heart attack is an epidemic and we need to have best possible penetration. So eventually it is the end user, that is in this case are the people who are affected by heart attack. They should be brought to the umbrella of best possible treatment to decrease the mortality. And it can only be done when every first medical contact point, so be it a primary healthcare, be it a clinician's own clinic, everywhere the facility should be linked, that the ECG should be read or should be opined by a cardiologist. So we need to have that kind of network, and looking at the distance and the cost effective, because unless the treatment is easy, safe and cost effective, that is not going to be implemented easily. So we are a nation which is resource starved, so we need to use our resources very carefully. So the easiest thing which comes to my mind and has been replicated in some part of the world as well, if you look at the Prague registry, there it was very well regulated that you don't have to create an open cath lab in every center. You need to link them. You need to, and pharmacoinvasive data is so robust, and then the beauty of that is that almost 30% of them would not need any further revascularization. So I would say that all first medical contact points where an ECG can be done should be immediately reported, and then it should be triaged to fibrin specific thrombolysis followed by the pharmacoinvasive strategy where the angiography can be done. It would take lot of effort, but a concerted effort, because we are doing it in North India as silos. We are just not coordinating between. So I think the government initiative has to be there, that if it is an heart attack, it should be nearest capable center and it should be interlinked so that we can give the best possible treatment to our patients, because it's more important for Delhi because our traffic is so bad that if somebody wants to go to from one zone to next zone, probably the golden period would be lost. And then the power of pharmacoinvasive therapy has to be looked at, because if you see that within 3 hours, if they are thrombolized, as Dr. Vinod Sharma said, then apparently the cost of cath lab and all those things is we can save that. And then given the amount of disease burden, we should reserve the early invasive treatment in people who do not have, who have failed thrombolysis, who have got cardiogenic shock and all those kind of things. So I think the educating the society and the education should go right from the schools, where the early recognition of, if you look at the data that patients who have come from a family where heart disease is there, they reach hospital far earlier than where the families who are, even if they have richest of the rich people, if the education of heart attack and symptoms is not there, they come quite late. So I think the education should be right from the school, it should not only be taught in medical schools but in the general schools also. And then the communication and linking all the health facilities together should be the priority.
I think it's very important, Dr. Viveka mentioned very important, that the realization of pre-hospital thrombolysis has come in North India now. In South India, it's existing for last many years. Worldwide, in United States or Europe, whole data is coming from there, whether it's a stream data or other trials like I mentioned to you, eternal registry data is very, very clear. And they are implementing as a routine that pre-hospital thrombolysis is the answer if you really want to salvage the jeopardized myocardium, because 90% of them cannot reach the hospital. The same thing is expressed by Viveka, that we must impart education, and this is the best media. I am very happy that FAM Health, Tata Sky FAM Health has taken this initiative, and I'm sure this communication will be perceived by almost 1 crore people. And they promised me that they will show it at least 48 times in a year. That means every week they will show us this program, so that there is a massive awareness, education in the people's mind how to attack heart attack, and they know what the symptoms are, so they go to a right person at a right time in a right place, and they don't go to a small nursing home or to a small center where the facilities are not there. Ultimately, all the patient has to land up in a hospital which has PCI capable. I think I'd like to ask Satyen Tiwari. We see sometimes patient had a heart attack, they had a stent, they had a PCI. Still, if they get chest pain and they get a second heart attack, what should they do?
Yeah, that's a very important and good question, because we do see patients who have already have a blocked arteries. It is immaterial whether it is opened by a drug or some procedure has been done. So the important thing is the early recognition by the physician, and then transport to a place where the facilities are there. So all these patients who have already undergone some procedures and already have a blocked arteries, so they should ideally have a proper treatment charting. They should have a card with them all the time while they are traveling. So they should know, the doctor should know what the drugs they are on and what are the places nearby from their residence that they should go if the symptoms or something has happened. So these are the patients should be registered and enrolled to the nearby places where they work or they reside. So that's very important for such populations.
So I think it's very important that whenever there is a chest pain, please be in touch with a cardiac center. Under the supervision and guidance of a cardiologist, the instructions will be given. People are using tele-EKG, they're using tele-echocardiography, tele-cath, tele-radiology. Whole world is changing. Recently in Gujarat, you heard that even tele-angioplasty was done. By a remote area, angioplasty was done. People are using robot, artificial intelligence. Digital media is playing a very, very important role. I am working on thrombolysis for the last 36 years. And I am totally convinced by the experimental model, by observational data, randomized data, meta-analysis, and a huge registry data, that it works very effectively. But none of our patients should be without a PCI. That's a very important message. So they complement. Ravi Kachliwal is doing a conference, I think on 13th or 14th, and he wanted me to speak only on pharmacoinvasive. Would you please highlight what exactly you mean by pharmacoinvasive for the common man?
Yeah, that's a good question. The pharmacoinvasive, as you have said, that those who can reach a hospital within an hour or so, they get a primary angioplasty. But those who are remote, and yet you do not want their heart muscles to be damaged, obviously, because if the heart muscle is damaged, he will be in the ravages of heart failure for entire life. So in those individuals where it is not available, you give the pharmacological drug, tenecteplase, or such what drugs that we call clot busters. Do not deny them the use of tenecteplase, as has been repeatedly said by every panel member, that a chest pain with ECG characteristic of a heart attack, don't deny them. It can be given in a good adequate facility under the care of a cardiologist. Once you have given the pharmacological route, at least you have been able to stabilize a patient, that if you think, and when the time is appropriate, you can then shift him to a center where all other facilities are available. They can have a good echocardiography, they can go to the cath lab if so required. And as has been said, you have also taken care of cardiogenic shock. Many of them would have gone into a cardiogenic shock with a proximal left anterior descending artery block. 30% of the heart muscle would have gone in 5 minutes. So truly here you have come with this dictum that there is something called the golden hour. You are sitting outside somewhere, like we have done at Medanta. What we have done is that some of our people who were fellows in our institute and are now located 5 to 10 kilometers away, they, on an iPad, they send us their ECGs of patients with chest pain. And we talk to them immediately. This is in the heart command center, that look, this is a heart attack. Whether the patient can afford or not afford is a secondary issue. But if the transport facilities are taking time, at least give them a clot buster drug. And that has saved many lives. Even if you reach the Medanta emergency room, you will not be taken into the heart command immediately. There is no need. In the triage, we have a chest pain unit. And if there is clearly ST elevation, then there is no need to go anywhere else. But whichever route you want to go, you can do it. Our door to balloon time is really quite less, and we can open up the arteries because, as has been said by every panel member, an open artery will salvage myocardium immediately. So I think pharmaco-invasive route is the way to go in India, both from the point of view of remoteness and also from the point of view of the chaotic traffic and the recognition. Sometimes the ECG may not be abnormal the first time the patient comes. The ECG becomes abnormal only after 1.5 hours or 2 hours when you do the second ECG, and then the troponins also increase. So I think in today's day and age, I think Dr. Chopra's work on this approach, which he will also highlight in our own meeting, makes a lot of sense. Just do not think a heart attack is equal to angioplasty, which can actually save a person. As somebody was saying, our people do it in the ambulance itself. So I think you've touched a very, very important point.
So very important message given by Dr. Ravi Kasliwal. Everyone, member of public, should know what a clot buster is. He also mentioned sometimes there may not be any classical EKG changes. So you may abort heart attack. You can make a large infarct to a smaller infarct, a transmural to a subendocardial infarct. You can also prevent the extension of infarct. And he also mentioned that you can prevent the cardiogenic shock. So it's very safe. The only thing is it has to be under the supervision of a cardiologist. He also mentioned that they have a chest pain specified beds in the heart command center, and we take a decision where to do what. If the cath lab is very busy, they straight away go for tenective place because no harm is created. It's only benefit. I think it's a very nice message, Ravi. Dr. Khanna, you see patients coming to you after 6 hours, they don't come in 3 hours. What do you think is the role of tenective place there? Should we not? Or let the patient suffer or die, or let him have more damage and your cath lab is too busy? What are you going to do?